Hello, my name is Han Vu Ngiem, and I'm a professor of radiology at Oakland University William Beaumont School of Medicine. And today I'm going to talk about ultrasound-guided intervention in the abdomen and pelvis. Imaging-guided intervention is definitely experiencing a period of unprecedented growth with continued advances in equipment technology and refinements in techniques, making the procedures safer. Ultrasound is at the forefront of this trend and becoming increasingly recognized as the premier guidance tool for an array of interventional techniques. Why is ultrasound the guidance of choice for so many procedures? The answer is both technological and economical considerations. So today I would like to discuss both the traditional and unique advantages of ultrasound as an image guidance tool and the utilization of these advantages in percutaneous ultrasound-guided biopsies and aspiration of intra-abdominal and pelvic masses and fluid collections. The many known traditional advantages of ultrasound as an image guidance tool include real-time imaging, which lead to increased accuracy with decreased procedure time and cost, real-time vessel visualization and multiplanar capability, portability and availability, and last but not least, a lack of inherent ionizing radiation. I'm going to use many cases to illustrate these traditional advantages of ultrasound as an image guidance tool. Here's a patient with a history of lung cancer, which was found to have a lesion in the dome of the liver adjacent to the right ventricle. A biopsy was requested, and the most appropriate and efficient imaging guidance tool would be using ultrasound guidance so that one can observe the needle excursion through the lesion during real-time imaging to ensure that the biopsy be restricted entirely in the lesion and not extending to the adjacent critical structure, which in this case, the right ventricle. Again, this is showing the utility of real-time imaging in assisting ultrasound-guided biopsy of this lesion to avoid injury of the adjacent critical structure. This lesion turned out to be a metastasis from lung carcinoma. This is a patient with cirrhosis, and there's a small 10 millimeter enhancing lesion suspicious for a hepatocellular carcinoma. Biopsy was requested, and again, ultrasound is a real-time imaging which permit the operator to watch this dynamic target move and also allowing for the target and the needle tip to be simultaneously seen in the field of view before the biopsy to ensure the accuracy of the biopsy, which yielded this lesion to be a hepatocellular carcinoma. Ultrasound can also be used for aspiration and drainage of superficial fluid collection, as seen in this patient with a perinephric fluid collection. So using ultrasound guidance, we can directly observe under real-time imaging the needle passing into the fluid collection. Aspiration was performed, through which a guide wire is seen traversing the needle into the collection. Next is the tract dilatation that is being seen when the catheter or the dilator is traversing the guide wire, and finally the catheter placement into the fluid collection. Again, all these steps of this aspiration and drainage procedure can be visualized at real time to improve the efficiency of the procedure. This is a patient with a pancreatic head mass, And this mass is adjacent to nearby large vasculature, and there's also a large artery traversing in the middle of the mass. Under ultrasound imaging, we can use the combination of grayscale and color flow Doppler to avoid injuring this critical artery to avoid post-procedural complication. This lesion turned out to be pancreatic adenocarcinoma. How about this case? This patient has a hypervascular mass which is situated between the right hepatic vein and the inferior vena cava. Biopsy was requested. With the multiplanar capability of ultrasound, we were able to select a safe approach into the lesion and also avoid the nearby vasculature to successfully biopsy this lesion, which turned out to be multifocal nodular hyperplasia. The multiplanar capability of ultrasound is also utilized in this case. This is a patient with breast carcinoma. There is a small left internal mammary lymph node which is suspicious for metastasis. With CT guidance, there is a potential penetration of the biopsy needle into the lung parenchyma, which may result in pneumothorax. Using ultrasound with its multiplanar capability, with a sagittal oblique plane, we were able to put the needle into this lymph node and successfully biopsy this lesion without complication, and the lesion turned out to be benign reactive lymph node, excluding the possibility or the suspicion of metastatic disease. The portability of ultrasound is crucial in patients who are critically ill and necessitate the procedure to be performed at bedside, as seen in this patient who is in the intensive care unit. The patient is intubated, unstable. The patient has a chest wall mass for which a diagnosis needs to be made. The procedure was performed at bedside, and here is the arrow that shows the needle in the chest wall mass. Again, the procedure was safely and successfully performed, confirming the suspected diagnosis of metastatic adenocarcinoma. The inherent lack of ionization is significant in pediatric and pregnant patient. This is a 15-year-old with chronic cough and an anterior mediastinal soft tissue mass for which biopsy was requested. This lesion was successfully biopsied under ultrasound guidance, which confirmed that this patient has indeed has a Hodgkin lymphoma. So we prefer to use ultrasound as imaging guidance whenever possible, and CT is reserved for cases in which the lesion is not seen by ultrasound, or the relationship of intra-abdominal mass cannot be adequately established with ultrasound, or when we feel that a safe pathway to the lesion is unlikely to be found by ultrasound, or when the patient's condition and cooperation would not make ultrasound guided feasible. Right now, I'm going to present to you the unique advantages of ultrasound guidance. One of the unique advantages is the biopsy of a very small lesion that is not visualized with non-contrast CT, or only visible with contrast-enhanced CT for a very short period of time, which is insufficient to allow CT-guided biopsy. Ultrasound also can be used for biopsy or aspiration of lesions that are not readily accessible with CT guidance, particularly in the area of the neck, region, the parotid gland in the peritonsillar lesion, and with a variety of approaches, including transvaginal, transrectal, or transperineal approaches, one can use for biopsy and aspiration and drainage of deep pelvic masses and fluid collection. The use of direct probe compression to displace bowel loops away from the biopsy targets also helped make a biopsy of mesenteric masses safe. And also with the direct probe compression, one can use that to staunch intraprocedural bleeding to minimize post-procedural bleeding complication. And last but not least, at times, the quick pre-procedure ultrasound lesion characterization can serve as a problem-solving tool, providing a reasonably confident diagnosis and thus avoiding unnecessary and potentially risky procedure. This is an example to illustrate those unique advantages of ultrasound as the image guidance modality. Here's a patient being worked up for a pre-stem cell transplant. On a contrast-enhanced CT scan, there are multiple small, tiny, hypodense lesions within the liver and also in the spleen. Since these lesions were not present on the previous study, a pathology was suspected and a biopsy was requested. These lesions are not seen on non-contrast enhanced CT, and as we know, they are only visible for a very short period of time after contrast enhancement, and therefore would be technically challenging if these lesions are performed with CT guidance. So ultrasound was used knowing that the lesions are there. We were able to localize several small 10 millimeter lesion, and once the lesion is localized with ultrasound, they will be persistent and consistently seen, allowing the accurate biopsy of these small lesions, which otherwise could not be performed using CT guidance, and this lesion turned out to be necrotizing granulomas. Here's a very interesting case, the patient with approximately 10 hepatic hemangiomas, and there is one single 8 millimeter lesion deep within the right lobe of the liver, which looks different, ring enhancing. A PET CT was performed which showed that this small single 8 millimeter lesion is hot on CT PET, suspicious for metastasis in this patient with known lung cancer. So again, this lesion would be very difficult to be biopsied using CT guidance, or probably impossible. And the ultrasound, using anatomic landmark, knowing where the lesion is, and also imaging characteristics of the other lesion being hemangioma, we were able to locate this small 8 millimeter lesion deep within the right lobe of liver and successfully perform a ultrasound-guided biopsy of this small lesion, which indeed turned out to be a single focal area of metastatic disease from lung carcinoma. Another area which is technically challenging, especially for CT guidance, is the area of the parotid gland and the peritonsillar and neck region. As seen in this patient with sensory neural hearing loss, and there's an incidental suspicious 8 millimeter nodule within the right parotid gland seen on this MRI exam. A biopsy was requested. And in this lesion, which is technically challenging with CT guidance due to its small size and location, ultrasound was used, and we were able to confidently localize this hypoechoic lesion, for which an ultrasound-guided biopsy was performed, which yielded a benign reactive lymph node and no evidence of malignancy. Ultrasound not only can be used for superficial lesion, but it can also be used for intervention of a deeper lesion in the neck area, especially in this area of peritonsillar region, as seen in this patient who has throat pain and dysphagia. A CT scan show a suspicious peritonsillar abscess, which compresses the oropharyngeal airway. Ultrasound was used because it allows us to find a safe tissue plane through which we can pass a aspiration needle and avoid the adjacent critical structure. This fluid collection was successfully aspirated, yielding purulent fluid, which was culture positive for strep viridans. This is also a very interesting case, highlighting the unique advantage of ultrasound in intervention. This patient who has a history of prostatitis with severe pelvic pain and recurrent urinary tract infection, not responding to multiple courses of antibiotic. The urologist was very frustrated, as was the patient. We recommend an MRI, and on MRI, there is a 2 centimeter rim-enhancing fluid collection within the prostate, given the clinical history, highly suspicious for an intraprostatic abscess. And due to the location and the small size of this fluid collection, ultrasound was performed. We used a transperineal approach because the patient had rectal sigmoid colon surgical history, which did not allow a transrectal approach. So the transperineal approach was used, and we were able to localize this fluid collection, and aspiration did indeed yielded pus. And at the same time, we instilled antibiotic into this abscess, and the patient experienced prompt clinical improvement during the clinical follow-up. This is a patient who is a 30-year-old female with a history of cervical carcinoma, status post-total abdominal hysterectomy. On a routine bimanual exam, the gynecologist palpated a 2 centimeter nodularity at the vaginal apex. The patient was referred for a diagnostic pelvic ultrasound and, if possible, a biopsy if a suspicious lesion was found. So here is a transabdominal exam which confirmed a small 2 centimeter soft tissue mass at the vaginal apex. Endovaginal exam again confirmed this soft tissue lesion, which is extremely hypervascular. And in the same setting, we were able to perform a transvaginal ultrasound guided biopsy of this lesion in the area of vaginal apex, expediting the diagnosis of recurrent cervical carcinoma. Here is a 4-year-old boy with history of rhabdomyosarcoma of the prostate. He's had a prostatectomy on the routine follow-up. A new mass was seen in the prostatic bed, suspicious for recurrence. Instead of using a transgluteal approach to access this lesion, we used a transrectal approach. And with the transrectal ultrasound, the mass was readily visible, and through which we were able to biopsy this soft tissue mass within the prostatic bed, confirming recurrent rhabdomyosarcoma. Now, another unique advantage of ultrasound guidance is the use of direct probe compression. As seen in this case, this is a patient with abdominal pain and a mesenteric mass. Biopsy was requested. We use ultrasound as a guidance tool, and with direct compression using the ultrasound probe, the bowel loops could be displaced away from the target, at the same time to decrease the distance between the skin surface and the target lesion, allowing safe biopsy of this mesenteric mass, which turned out to be a benign reactive node without malignancy. Again, in doing so, we were able to avoid the potential injury of the adjacent bowel loop, which may cause perforation of a viscus organ. The utility of direct probe compression is also illustrated in this patient who complained of oozing at the paracentesis puncture site. The patient was brought down and scanned. Color flow Doppler show a small active bleed at the puncture site, and with direct compression using ultrasound over the bleeding site, after 10 minutes of direct compression, we were able to stop the oozing, and the cessation of active bleeding was also confirmed at real-time color flow Doppler imaging. The use of direct probe compression over the biopsy site when there is no intervening bony structure to manage intraprocedural hemorrhage is also extremely helpful, as seen in this patient who we perform a biopsy of a native kidney in the immediate post-procedure. And under real time, there is a small perinephric hematoma, but more significantly, there's a small active bleed. Direct compression using probe upon the biopsy site was utilized. After 10 to 15 minutes of compression, the active bleeding was stopped. Perhaps it's the combination of direct probe compression and the tamponade effect and the time that allow platelet aggregation. Maybe the combination of all of the factors above help manage this active bleeding that was visualized intraprocedurally and minimize post-procedural complication as seen in this case. This is also an interesting case highlighting another unique advantage of ultrasound guidance. So here's a patient with abdominal pain. CT scan show a rim-enhancing fluid collection in the pelvis, suspicious for an abscess. Aspiration and drainage was requested. So during the quick, routinely performed pre-procedure ultrasound imaging, we realized that this, quote, fluid collection actually corresponding to the ovaries, both right and left ovaries that were positioned in the cul-de-sac, which simulate fluid collection on the CT. So with the, and there was no fluid collection in the pelvis. So using the lesion characterization during the quick pre-procedure ultrasound scanning, we were able to avoid the aspiration and drainage procedure, which is also a potentially risky procedure in this patient. Another example to highlight the unique advantage of ultrasound seen in this patient who on an outside study show a 12 millimeter enhancing renal mass. Biopsy was requested. During the pre-procedure scanning, again, the mass is extremely echogenic, suspicious for a benign angiomyolipoma. We take the patient over to CT scan. A few limited scans were obtained through the lesion, which confirm intralesional presence of fat consistent with an angiomyolipoma. Therefore, biopsy was not performed. So at time pre-procedure ultrasound scanning with the lesion characterization can provide a reasonably confident diagnosis, which allow us to avoid performing an unnecessary and risky procedure as seen in this case. How about this patient who has a known renal mass suspicious for renal cell carcinoma and 2 hypodense lesions within the liver suspicious for hepatic metastasis? Biopsy of the liver was requested. During the scanning, the lesion in the right lobe appeared to be extremely echogenic with possible through transmission, suspicious for a benign hemangioma of the liver. Scanning the second lesion in the left lobe showed a more suspicious ill-defined hypoechoic lesion. with the imaging characteristic, the second lesion was chosen to be biopsy, which indeed turned out to be metastatic renal cell carcinoma, and the first lesion was indeed later on shown to be a hemangioma. So this unique advantage of ultrasound lesion characterization really highlights the benefit in the lesion selection in patients with multiple lesions to improve the diagnostic yield. Another patient with a hypodense lesion on an outside CT scan referred for biopsy. On the day of the biopsy, the lesion seemed to be or appears to be echogenic with some lobular margin, probably a hemangioma. So should we proceed with the biopsy, or should we stop and recommend an MRI? The lesion characteristic is very suspicious for a benign mass, so we recommended an MRI, which was performed during the next day, and indeed proved that a lesion turned out to be a hepatic hemangioma with the typical characteristic on the T2 and contrast-enhanced images. This patient therefore did not have a necessary biopsy procedure of this benign hepatic hemangioma. So I'm going to, at this time, discuss a few technical highlights concerning liver and renal biopsy and transvaginal and transrectal biopsy and aspiration of lesion and fluid collection. With regard to liver lesion biopsy, a subcostal approach is always preferred when possible because it eliminates the risk of pneumothorax and potential lacerated intercostal vessels, but it may require steep needle angulation. Subcostal approach is excellent for lesion in the left lobe and in the mid to lower portion of the right lobe, but an intercostal approach usually has to be used for lesion which is high in the dome. It's also pretty safe. It rarely results in pneumothorax unless the lung is transgressed. When performing a liver lesion biopsy, we should avoid direct puncture into the lesion by choosing a path with intervening normal liver for tamponade effect and to minimize post-procedural bleeding complication. And if there is brisk bleeding during the procedure, we often use a coaxial approach with a 17-gauge introducer and 18-gauge biopsy a needle. If there is a brisk bleeding or blood return from the introducer, we use compression or a combination of compression when possible with autologous clot or a procoagulant agent if needed, such as a Hilotine or gel foam. Here is a patient with a subcapsular lesion somewhat high in the liver. A subcostal approach was used, but it did require steep angulation, but we were able to reach the lesion and successfully and safely perform the prior biopsy of this lesion, which turned out to be a hepatocellular carcinoma. Here's a patient with a very high lesion in the dome of the liver, so an intercostal approach had to be utilized, but this is relatively safe as long as the lung is not transgressed and the lung can be readily seen at a real time. But as you can see here, this echogenic structure that is moving with respiration was the lung and the lung edge, and we should avoid transgressing that and avoid the pneumothorax as a potential complication. So here is a biopsy of a large hypovascular hepatocellular carcinoma. We did choose the path through intervening normal liver parenchyma, but there was very brisk bleeding through the introducer after the procedure, in this circumstance, you can use the autologous clot to help stop the bleeding, or use a coagulant. In this case, we use Helitin to embolize the tract, and we were able to stop the bleeding during the procedure. And this patient also did not develop post-procedural bleeding complication. In contrast to this large hepatocellular carcinoma, unfortunately, a direct puncture approach was used, and immediately after the procedure, the patient experienced extreme pain, hypotension, consistent with hemorrhage. A contrast-enhanced CT was performed that showed active extravasation and a large amount of hemoperitoneum in this patient with active bleeding. The patient was immediately taken over to the angio suite. An active bleed was found and was successfully embolized using coil embolization. So definitely one should try to avoid direct puncture, especially of the hypervascular lesions such as hepatocellular carcinoma, to minimize post-procedure bleeding complication. With regard to native and transplant renal biopsy, one should choose a safe trajectory or needle path, and the needle path should point toward the polar cortex, preferably the low pole. You can also use the upper pole as long as the needle path is only pointing to the pole and not directly into the renal hilum, which increase the risk of post-procedural hemorrhage, as seen in this case with a risky needle trajectory that directly into the renal hilum, which resulted in a post-procedure perinephric hematoma. Additionally, the pathologist only need the cortex and not the medulla. So again, the needle path should be pointing into the cortex of the polar area of the renal parenchyma. One of the significant complications of renal biopsy in that of a formation of an arteriovenous fistula. Many times a very small fistula will spontaneously thrombose without significant symptom, or at times a large arteriovenous fistula may also result, which require embolization. But sometimes even a small arteriovenous fistula can also be very symptomatic, as seen in this patient with a small AVF, but with gross bloody hematuria which did not stop, and the patient was severely symptomatic. The patient was taken to the angio suite, confirming a small arteriovenous fistula, which was then coil embolized. Transrectal and transvaginal approaches can also be used for access deep pelvic masses and fluid collection. It's relatively safe, somewhat less painful for the patient compared to transgluteal approach. So when the transgluteal approach could not be used, transvaginal and transrectal approach could be utilized. If one is using transrectal approach, antibiotic coverage prior to the procedure is strongly recommended to prevent post-procedure biopsy risk of abscess formation. We routinely perform these procedures under conscious sedation. So an endocavitary probe is used, and there are a number of adapter or devices that can be attached to the probe to help simplify the procedure, either with either for aspiration, catheter drainage, or biopsy, as illustrated in this case. This is a patient with a history of ovarian carcinoma. On the routine follow-up, there is a suspicious solid and cystic mass concerning for recurrence. transrectal ultrasound guided biopsy was performed, again confirming both the cystic and vascular solid component of the mass. Through the transrectal approach, we aspirated the cystic component and also biopsy the solid component, and both yielded recurrent ovarian carcinoma. Ultrasound-guided transrectal drain placement could also be used to manage deep pelvic or perirectal abscess, as seen in this patient with a perirectal fluid collection suspicious for an abscess. Via a transrectal approach, you can see this complex fluid collection through which a needle can be placed into the fluid collection for aspiration and conformation of a purulent fluid. Then through a trocar approach, the catheter can be placed into this fluid collection, as you can see here, as the trocar catheter inserted into the abscess collection, and placement of the catheter was then can be done and under ultrasound the catheter was confirmed to be the fluid collection. During several days after the catheter placement, a CT was performed confirming complete decompression and drainage of this perirectal abscess. So in conclusions, ultrasound is increasingly recognized as the primary imaging guidance tool for many interventional procedures due to its many advantages over other guidance modalities. And as equipment technology continues to improve, the shift of procedures away from CT guidance will continue, and ultrasound will become the guidance of choice for most interventional procedures. Thank you very much for your attention.